Thank you for the warm introduction. அனைவருக்கும் இனிய காலை வணக்கங்கள். Good morning to one and all. First of all, I would like to thank our Manipal Hospital management and our nephrologist Dr. Ashok Kumar sir for giving me this great opportunity to speak in this forum on World Kidney Day. The topic given to me is diabetes mellitus and kidney. Diabetes mellitus is defined as common metabolic disorders that share the phenotype of hyperglycemia. There are different types of diabetes mellitus. Those are type 1 diabetes mellitus, type 2 diabetes mellitus, pancreatic diabetes, gestational diabetes mellitus, and some specific types like MODY 1, MODY 2, MODY 3. And we will see these types one by one. Type 1 DM is characterized by complete absence or severe deficiency of insulin. This is result of autoimmunity directed against the beta cells of pancreas. Usually, type 1 DM develops before the age of 30. But around 10% of individuals who develop diabetes above the age of 30 are diagnosed to have type 1 diabetes. And coming to type 2 DM, this is characterized by insulin resistance, impaired insulin secretion, and increased hepatic gluconeogenesis. And type 2 DM is developing in increasing age. But nowadays, this type 2 DM is being diagnosed more frequently in children and in young adults, that too particularly in obese adolescents. And coming to some specific types like MODY, this is maturity onset diabetes in young. This usually develops in less than 25 years. This is not insulin dependent. This is due to genetic defects in beta cell function and beta cell development. This is not insulin dependent diabetes. This is due to genetic defects in beta cell development and functions. And coming to pancreatic diabetes, these two conditions, cystic fibrosis and chronic pancreatitis. In these two conditions, there is already an exocrine pancreatic damage. Eventually, these patients develop endocrine pancreatic damage, also developing diabetes. And Cushing's disease and acromegaly. In these two conditions, there is an excess of insulin antagonistic effect. In Cushing's disease, there is an excess of ACTH, and in acromegaly, there is an excess of growth hormone. And coming to viral infections, viral infections can also attack directly on beta cells of pancreas, can cause diabetes mellitus. This is a very rare phenomenon, but this also is there. But what we have seen in COVID time, a lot of COVID patients developed diabetes, that they developed glucose intolerance in post-COVID phase. So, but this is a short-lived phenomenon, but viral infection also a rare cause of diabetes mellitus. In 80% of type 1 diabetes mellitus patients, they show the antibodies, autoantibodies positive status, but around 20% of type 1 diabetes mellitus patients are not presenting with antibody status, positive antibody status. So in those cases, viral infections could have played an important role in causing the type 1 diabetes. And coming to gestational diabetes mellitus. Gestational diabetes mellitus is defined as glucose intolerance developing in second or third trimester of pregnancy. An interesting fact is 1 in 7 pregnancies worldwide is having either gestational diabetes mellitus or pre-existing diabetes mellitus complicating pregnancy. And the risk of gestational diabetes mellitus patients developing into diabetes mellitus type 2 is 35 to 60% in next 10 to 20 years. Also, children born to gestational diabetes mellitus mothers are having increased risk of developing metabolic syndrome and type 2 diabetes mellitus in later life. Coming to the criteria for the diagnosis of diabetes mellitus, as you all know, the fasting plasma glucose should be more than or equal to 126 mg per deciliter, and 2 hours after 75 grams glucose should be more than or equal to 200 mg per liter and per deciliter, and HbA1c of more than or equal to 6.5. This is the diagnostic criteria for diagnosing diabetes mellitus. And coming to gestational diabetes mellitus is diagnosed with giving 50 grams of glucose in 24 to 28 weeks of pregnancy. If it is more than 140 milligram per deciliter after 1 hour, they have to further undergo 100 grams of glucose test. And these 4 values, the fast after 100 grams of glucose, the fasting should be more than or equal to 95, and 1 hour sugar should be more than or equal to 180, more than or equal to 155 in second hour, more than or equal to 140 in third hour. Any 2 of these above values are abnormal, then they will be termed as gestational diabetes mellitus. Coming to the complications of diabetes mellitus. Complications can be divided into vascular and non-vascular complications. What are the, first we will see the non-vascular complications. Non-vascular complications depending upon the systems. In gastrointestinal system, it can cause diabetic diarrhea, constipation, gastroparesis. All these complications can occur due to diabetic autonomic neuropathy, followed by genitourinary complications like erectile dysfunction, cystopathy, uropathy, and coming to dermatologic complications like diabetic dermopathy, necrobiosis lipoidica, diabetica, and more importantly, infections, respiratory tract infections, urinary tract infections, and skin and soft tissue infections can occur due to diabetes. Coming to ophthalmic complications, cataracts, glaucoma can occur due to complications, and a condition called cheroarthropathy. This is due to increased blood sugar. The condition is reduced mobility of joints. Mobility of joints due to thickened skin. That is called cheroarthropathy. And coming to CNS complications like dementia, cognitive impairment, hearing loss, and periodontal diseases. And coming to vascular complications are divided into microvascular complications and macrovascular complications. Microvascular complications are diabetic neuropathy, diabetic retinopathy, and diabetic nephropathy. Macrovascular complications are coronary artery disease, peripheral arterial disease, and cerebrovascular disease. The difference between these microvascular and macrovascular complications are: microvascular complications are purely hyperglycemia related, but macrovascular complications are both hyperglycemia and insulin resistance related. So controlling the HbA1c and blood sugar alone will give some protection against microvascular complication, but here macrovascular complications, controlling the blood sugar alone will not give full protection against this macrovascular complications. So controlling the pressure, controlling the sugar, controlling the cholesterol levels, all these things play in preventing the macrovascular complications. Coming to pathological changes that occur in diabetes mellitus. This is divided into earlier changes and advanced changes. What are the early changes? First and foremost change is glomerular hypertrophy, that is increased intraglomerular capillary pressure, followed by renal hypertrophy and increased GFR, followed by glomerular basement membrane thickening due to accumulation of extracellular matrix proteins, mesangial expansion. This is due to increase in mesangial cell number and matrix, leading to narrowing of capillary lumen. And coming to advanced changes, there is nodular glomerulosclerosis, that is nodules in the glomeruli composed of mesangial cells and matrix called as Kimmel-Steele-Wilson's lesions, that is pathognomonic of diabetic nephropathy, followed by diffuse glomerulosclerosis. Here there is widespread scarring of glomeruli will be there, followed by tubulointerstitial fibrosis, followed by arteriolar chylinosis, and finally global glomerulosclerosis, that is complete scarring of glomeruli, complete kidney dysfunction. Yes, this slide I took it from Harrison, very interesting one. This green line, above green line indicates the time from onset of diabetes. 0, 3, 5, these are years. The below line indicates GFR and albuminuria. So in first 5 to 10 years, there is an increase in GFR. You can see the GFR increases from 120, 130, 140, 150. It is an increasing trend. So in initial stages of diabetes mellitus, there is an increase in GFR, followed by after 10 to 15 years of diabetes, there is a decline in GFR. But albuminuria occurs before the fall in GFR. Now coming to the urine albumin creatinine ratio. What is urine albumin creatinine ratio? This is for diagnosing and monitoring of diabetic nephropathy. The normal albumin creatinine ratio is less than 30 milligram per gram. If it is more than or equal to 30, less than 300, then they are called as microalbuminuric. And if the albuminuria range is above 300, they are called as macroalbuminuric. 2 consecutive tests should be positive in 3 to 6 months. And there are a lot of conditions causing false positive results. Those conditions are short-term hyperglycemia, urinary tract infections, exercise, heart failure, and acute febrile illness. In all these conditions, false positive results can be expected. So in these conditions, the test should be repeated. And coming to DKD classification, diabetic kidney disease classification according to American Diabetes Association. DKD class can be classified into 5 stages based on the presence and severity of albuminuria and decreased GFR. Here, as we have already seen in the previous slide, that the albumin creatinine ratio increasing before the declining GFR. So, what is the normal kidney function? The normal, to say a patient is having normal kidney function, the UACR should be less than 30. Urine albumin creatinine ratio should be less than 30, and the GFR should be more than 60. So this is the normal kidney function. And in stage 1 DKD, the GFR is normal. GFR is more than 60, but the albumin is getting increasing. That is UACR of more than 30, but less than 300. This is the stage 1 DKD. In stage 2 DKD, the UACR is 30 to 300 milligram per gram. GFR starts falling down. In stage 2 DKD only, the GFR starts falling down. In stage 1 DKD, the GFR is normal. That's a major difference you should note. In the stage 2, the GFR is 30 to 59. In stage 3, the UACR is more than 300 milligram per gram. And GFR is 30 to 59. In stage 4, UACR more than 300 milligram per gram. And GFR is 15 to 29 ml per minute. In stage 5, UACR is more than 300 milligram per gram. GFR is less than 15 ml per minute. Or a complete kidney dysfunction requiring renal replacement therapy. Coming to preventive aspects, tight glycemic control, maintaining the HbA1c less than 7 to slow the disease progression, and BP management, target BP of less than 130/80 plays an important role in prevention of DKD, and healthy lifestyle, healthy diet, regular exercise, weight reduction, and smoking cessation. All these things play an important role in prevention of DKD, and regular monitoring of urine albumin creatinine ratio and GFR for the early diagnosis of DKD. And some interesting facts about the diabetes mellitus. Only 20 to 40% of diabetes mellitus patients develop diabetic nephropathy. Only 20 to 40% of diabetes mellitus patients develop diabetic nephropathy. So, some additional genetic and environmental influences play an important role. It remains to be identified. As we have already seen that smoking cessation, weight reduction, healthy diet, all these things could play an important role in prevention of DKD. Coming to diabetic retinopathy, most of the patients with diabetic kidney disease also have diabetic retinopathy. So, annual ophthalmic examination is very important in those patients. Coming to type 4 RDA, this is a hyporeninemic hypoaldosteronism may occur. It may occur in type 1 diabetes mellitus or type 2 diabetes mellitus. Here there is a propensity for hyperkalemia and acidemia, which may be exacerbated by ACE inhibitors, angiotensin type 2 receptor blockers, and mineralocorticoid receptor antagonists. So caution should be taken before putting the patient into ACE inhibitors and ARBs. And coming to contrast nephropathy. Diabetic nephropathy patients undergoing contrast procedures are having chances of developing diabetic contrast nephropathy. So the baseline creatinine value and potassium value should be documented before giving any contrast procedures. Okay, and all those patients, diabetic nephropathy patients undergoing contrast procedure should be well hydrated before and after the procedure, and if they are taking metformin, that should be withheld before the procedure. And coming to the treatment part, here I would like to mention these 5 classes, important classes of drugs which are used for treatment in diabetic nephropathy. Angiotensin converting enzyme inhibitors, angiotensin receptor blockers, SGLT2 inhibitors, steroidal mineralocorticoid receptor antagonist, and non-steroidal mineralocorticoid receptor antagonist. We will see one by one. AC inhibitors, it blocks the conversion of angiotensin 1 to angiotensin 2, a potent vasoconstrictor that contributes to kidney damage. It reduces intraglandular capillary pressure, thereby reducing the proteinuria. It increases the level of bradykinin, a potent vasodilator that helps to relax the intraglandular capillaries, and also reduction of BP. It improves the kidney function, and monitoring of potassium levels and creatinine is must whenever a patient is getting periodical monitoring is must whenever a patient is getting AC inhibitors. And due to this increased levels of bradykinin, patient can develop complications like adverse effects like chronic cough and angioedema. And angiotensin receptor blockers. Angiotensin receptor blockers, it blocks the effects of angiotensin 2 on the angiotensin type 1 receptor, which is involved in vasoconstriction, inflammation, fibrosis of kidney. It reduces intraglandular pressure, proteinuria, and slows the disease progression. It increases nitric oxide production, thereby reducing the BP and intraglandular pressure. And both ACE inhibitors and ARBs reduce proteinuria, reduce cardiovascular risk also, and improve kidney function. And ARBs are having better tolerability since there is no increased bradykinin levels. There is no chances of developing chronic cough and angioedema here. And as I have already said, that creatinine and potassium monitoring is must. And if needed, AC inhibitors and ARBs can be combined. Coming to SGLT2 inhibitors. SGLT2 inhibitors are novel class of drugs which blocks the sodium and glucose co-transporter 2 in proximal convoluted tubule. Reduces glucose reabsorption, also sodium reabsorption. It has been shown to reduce proteinuria, slows the decline in GFR, reduces kidney fibrosis, and it helps to reduce the BP also, and also it reduces the cardiovascular risk also. And adverse effects in SGLT2 inhibitors are urinary tract infection, genital mycotic infections, and hypotension. In these classes of drugs are contraindicated in patients with severe kidney impairment or ESRD patients undergoing dialysis. The last one, finerenone. This is a non-steroidal mineralocorticoid receptor antagonist, and these two drugs, spironolactone and eplerenone, are steroidal mineralocorticoid receptor antagonists. The comparison between these three drugs, this finerenone is having a very good potency when comparing these two. What we are using is nowadays spironolactone, and comparing spironolactone and eplerenone, the finerenone is having a very good potency, also a very good selectivity for mineralocorticoid receptors, and there is no CNS penetration when comparing this eplerenone and spironolactone. Finerenone is having no CNS penetration and no sexual side effects, no gynecomastia, and half-life is 2 to 3 hours only. When comparing with this spironolactone, this is 20 hours, more than 20 hours, eplerenone is 4 to 6 hours, here only 2 to 3 hours, and there are no active metabolites. The kidney to heart distribution is 6:1 in spironolactone, 3:1 in eplerenone, and finerenone, this is 1:1. So finerenone can be tried in patients with CKD associated with the type 2 diabetes mellitus, and risk of hyperkalemia is also low when comparing with this eplerenone and spironolactone. Thank you. Any doubts I can?
what stage you refer a patient to nephrologist?
Whenever the urine albumin creatinine ratio is more, I always get a nephrologist opinion. Urine albumin creatinine ratio is more than 30, I will get a nephrologist opinion. In those patients, definitely I will get a nephro opinion.
Urine albumin is early detection.
Yes. Before developing the decline in GFR, urine albumin creatinine ratio is the first and foremost investigation to diagnose diabetic nephropathy.
Even 1 plus itself is significant.
No, that we cannot say like that. We have to do a urine albumin creatinine ratio.
Regarding the proteinuria, there is something called transient proteinuria. Even physiological stress, sometimes you do a heavy exercise, then you take a urine sample, it can show proteinuria, or following fever, or